Hello and welcome to my presentation. Today, I would like to show you how we could use learning principles to strengthen cognitive reserve in dementia. Dementia affects a lot of people. It is currently estimated that roughly 50 million live with the consequences of dementia. This number is estimated to increase to 150 million by the year 2050. This is causing a large burden on the society. Moreover, since the patients will display deficits in various cognitive domains, so they will not only have memory deficits, but as well problems with attention or executive functioning. Moreover, these people are facing behavioral and psychological changes. So they have changes in their personality, or they will have symptoms of anxiety or depression. As varied as the symptoms are the causes or risk factors for dementia. On one hand, it has been shown that low educational level or obesity and diabetes, as well as low physical activity and smoking and depression could lead to Alzheimer's, and Alzheimer's is one of the main causes of dementia. Unfortunately, there's currently no cure for Alzheimer's or any other cause of dementia. Hence, there's very low evidence that patients could actually improve. So the intervention currently mainly focuses on maintaining the current cognitive functioning of demented patients and is addressing prevention, such as preventing cognitive decline or preventing risk factors. However, if we are looking into novel ways to aid these patients, we have to bear in mind that many of these risk factors are actually related. So has low physical activity been linked to obesity or diabetes? And obesity and diabetes, on the other hand, has been linked to lower educational level. On the other hand, lower educational level has been linked to habitual smoking. And all of these factors have been linked to depression as well. So if you want to provide, or for instance, change the diet habits of demented patients, we might have also to aid them in maintaining a more active lifestyle. And we have also to, at the same time, to strengthen their cognitive reserve through cognitive training. Ideally, we would also allow them for social interaction, since this is beneficial to reduce depressive moods. These interdisciplinary approaches, or an interdisciplinary approach like this, has actually been studied in a large sample of elderly citizens. In that study, 1,260 patients, respectively half of them, underwent a 2-year multi-domain approach. The authors found that patients that participated in this 2-year multi-domain training showed not only an improvement in general cognitive performance, but they also maintained or increased their executive function ability and their processing speed, as in comparison to the control group that did not go through a multi-domain training. Moreover, this patient reduced their body mass index, and also they were able to positively influence their dietary habits, and they were able to increase their physical activity, which is a very positive consequence. However, it seems that an approach like this is quite resource intensive, since not all of the intervention group could participate in these 4 domains, but had to do one or the other, or at least one of them. So we have to think of novel ways if how to provide such a multi-domain approach, but in a more effective way, so a large number of patients could actually participate in it. And we as a group have been, since the last 15 years, looking into ways to provide such a multi-domain approach to patients that suffered from a stroke. So we have been looking into how to aid recover motor functions due to hemiparesis, or how to train various cognitive functions together. And also we addressed language deficits that stroke patients might display. And I would like to show you here what we have been learning by studying or finding novel rehabilitation approaches to address these various cognitive deficits after stroke. So first, before starting to look into novel rehabilitation approaches, we have to kind of identify the main goals of rehabilitation, rehabilitation. So on one hand, we have to make sure that, yes, the patients, they have to improve their functionality or at least maintain the status that they currently have. We also have to make sure that the rehabilitation is retained for a long period of time so that they don't deteriorate. And also, we would like to generalize to other functions that we might not directly address in the rehabilitation setting. So with these three goals in mind, we have been looking into novel methods, and we have been reverting to, or we have been using technology because we believe that technology can aid us to better address these three goals. So the system that we have been developing, that is called the Rehabilitation Gaming System, is a VR-based approach to address multi-domain deficits. We believe it is more effective because we incorporate principles of learning that have been shown already before in healthy people to gain superior effects. So the patients that interact with this with RGS, they are asked to perform goal-oriented movements or actions to achieve a task. Also, they observe their own movements while they're executing it. This is accomplished because we use a Kinect that is able to track the patient's movements and translates them to a virtual avatar that he can observe on the screen. Through these training scenarios, we can also influence which body parts are used during the training. So either the whole body can be trained, or we can also just promote that the more affected limb can be trained. Also, we provide the patient with a very variable practice. So he has to explore various motor patterns or cognitive strategies to accomplish the task. And we can fully adapt the system to the abilities of the patient. We can adjust the difficulty to the patient's abilities. And we provide auditory and visual feedback at the same time, so the patient is able to learn and whether he has accomplished the task successfully. We have been looking into whether systems that provide such a principled training to the patient, whether they are more superior than systems that do not include this type of principles. And we have been showing that principle-based systems like RGS are better in recovering body function and activity than off-the-shelf systems, so systems that do not incorporate these learning principles. So in the next few slides, I would like to present you what we have been learning by applying such a principle-based approach to the recovery of stroke patients. So let's start what we have been seeing when we targeted motor relearning after stroke. So one of the main issues, or one of the main phenomena after stroke, is that the patient starts to rely more on his healthy limb to accomplish certain tasks. This is a phenomenon that has been coined learn non-use, because the patient learns not to use his paretic limb for daily activities. A very common approach to reverse learn non-use is the constraint-induced movement therapy. So within that therapy, the healthy limb of the patient is constrained, so he's forced to use his paretic limb to accomplish these tasks. Although this approach is very successful, it has several drawbacks. It is very, very intensive for the patient, and also only a limited number of not so severely impaired patients can actually participate in this kind of therapy. So we have been thinking if there's an alternative to overcome learn not use. So by using RGS, we have found a way to promote the use of the paretic limb, and by actually reinforcing the use of the arm. We were able to accomplish this because we can modulate the mapping between the real limb and the virtual limb that is presented during the training. And we can manipulate it in a way so that the patient actually is perceiving that he's better than he actually is, because we can steer the movement of the patient towards a given goal, and hence provide him with a better or an augmented visual motor feedback that gives him the impression of more success and less error. We have been testing this paradigm in a clinical trial, and when we looked at two groups, so one group that was training with this movement amplification and compared them to a group that did not have this movement amplification, we saw that the group with the amplification actually over time was more selecting their impaired limb during this training. And this had also a positive influence on their impairment level. So although both groups improved right after the training, only the experimental group, so the group with the movement amplification, continued to improve after the training ended, so displayed a less impairment in their paretic limb. And this result is very interesting because it shows that, or it could be interpreted that these patients, since they learned to use more their paretic limb, they incorporated this into their everyday life, and hence were able to reduce their impairment level. In addition, we have been looking into using a similar approach for overcoming aphasia. Language problems like aphasia are currently treated in a one-to-one setting with a therapist, and they're hence a bit detached from like normal day-to-day life, how language would be used, since the patient is mostly asked to repeat words or remember words that he has to then to produce. So when we were thinking how to overcome these limitations, we thought, like, in virtuality, we can actually allow the patient to interact with other patients at the same time. So we developed a paradigm where the patients have to request and give objects, virtual objects, to their partner, and this tends to provide the training with a more language action related context, which corresponds to a more real life setting. We have been looking at how this training would influence language skills, and in a clinical trial where we had a control group that did standard language therapy, and we compared them to an experimental group that trained with this interactive multiplayer scenario. We saw that Initially, both groups improve at the end of the treatment, but again, only the group that actually was training with the interactive RGS multiplayer scenario showed a significant improvement at follow-up. And again, this interesting result might point to the fact that patients were able to transfer what they have learned during the training to their everyday life, and hence, through the enhanced use of their language, reduce the impairment that they initially had. Similarly, we have been looking into how provide the principle-based RGS training to address various cognitive deficits. In current standard therapy, like occupational therapy, cognitive deficits are kind of addressed very in isolation. So patients undergo like dedicated attention training or memory training or executive functioning training. But actually, patients typically express deficits in various cognitive domains at the same time. So just addressing one cognitive domain might be not as efficient. Also, if we think about like everyday tasks, then they require most of the time the close interplay of various cognitive domains to accomplish them. So in order to provide a more conjunctive cognitive therapy, we again reverted to the principles underlying RGS and the RGS itself, but we had to find a way how to address these various cognitive domains in conjunction. And so we reverted to the adaptive difficulty mechanism that adapts the difficulty automatically to the individual impairment level of the patient. It has already been shown that an optimal challenge, which means that it is subjectively not too easy and also not too difficult for somebody to achieve, leads to superior learning effects. We have been also looking at this hypothesis in a clinical trial. And we first looked at, well, is a system like that able to actually address these different cognitive impairment levels that patients might have? So here we see the difficulty level achieved in a task where patients had to remember sequences of stars. And we see that patients with a more severe impairment level have easier constellations to solve than those patients that have milder cognitive impairment. But we also see that through the course of the training, that independent of their impairment level, patients could solve more difficult tasks. So they were getting better at solving this task. However, independent of their impairment level, all the patients were exposed to the same success rate. So they all perceived that they were doing the task well, independent of their individual impairment level. So the system was optimally able to adapt to the patient's performance. We then also looked at how this translates to improvement in various cognitive domains. And we saw that the group that was training with this adaptive approach was better after follow-up in attention, spatial awareness, generalized cognitive functioning. And they were better than the standardized, better than the control group that did standardized tasks at home. In addition, we found that these patients that trained with the adaptive mechanism also were able to lower their depressive mood. And they remained significantly different from the control group also at follow-up. So again, this approach might lead to changes, or the training approach might lead to changes that transfer to everyday functioning of the patient, and hence allow them to more rely on their cognitive abilities in everyday tasks. So how could we now extend what we have been learning in motor, language, and cognitive training from what we have been learning from these training approaches in stroke population to how can we translate that to people with dementia? So for instance, using RGS and implementing the movement amplification, which augments the movement of a patient, we can promote maybe a more active lifestyle. We can give the patient the ability to train depending on his own performance level. By using the adaptive difficulty mechanism that adapts the difficulty of the task in order to provide the patient with the optimal challenge point, we might be able to address also the various cognitive deficits that demented patients can display. And we can also maybe help them to form new habits which are necessary in order to change, for instance, the diet that the patients will have, or also lifestyle habits like smoking that also requires to acquire new habits. By allowing the patient also to interact in a more, let's say, naturalistic way with other patients or with their caregiver, we might also address the need for interaction that is typically given through group therapy. And group therapy is maybe not always possible, or not possible in that extent that it is necessary. So we can extend this training to the virtual world and address more patients with this approach. Moreover, we have been working on ways to bring the RGS system or the RGS principle-based training to the patient's home. We are currently working on an application that can be played on a standard mobile phone and that interacts with a bracelet or a smartwatch, allowing the patient to continue the training that he might have started at the clinic or in an outpatient center, allowing them to continue that training at the home and together with their informal caregiver, which is also in dementia one of the main characters to aid the patient to maintain their cognitive abilities that they might have. With this, I would like to close my talk. I would like to thank you that you have been listening to me, and if you have any question, we are more than happy to get in contact with you. Just drop us an email and we can continue the discussion on this topic. Thank you very much.